So because everything was already said about inverted papilloma, I'll focus just on the malignant tumors so that we shorten the time. So sinonasal malignancies are very rare pathology. It's a diverse pathology. It accounts approximately 3% of the all head and neck tumors. So it's very, very rare when you encounter it, and therefore not much of the research can be done in a single institution for that. So what we have is that there are different, and there's a lot of histologies, but we are focused on the big five that we'll see later on, especially adenocarcinoma, which is in this region probably the most frequent malignant tumor on the sinonasal tract. So what do we know? We know that there's the big five. One is adenocarcinoma, intestinal and non-intestinal types, which are probably two different varieties, which is also reflected with total different outcome scores with intestinal and non-intestinal intestinal adenocarcinomas. There's squamous cell carcinoma and the SNUC, which could be at one point it's very hard to differentiate it, especially there is a coverage between the undifferentiated squamous cell carcinoma and the SNUC, and you have to have a genetic markers to differentiate those two entities, which is a very, it's just the paper came out in the head and neck from the MD Anderson experience, where they have a genetic markers where you can also point out or pinpoint the SNUC compared to the sinonasal undifferentiated carcinoma, but nevertheless, even though there might be genetic difference between those two entities, the treatment is all the same. Then there's the sinonasal melanoma, which we all know, which is not that uncommon, and the prognosis is basically poor, and the olfactory neuroblastoma, which we heard today. So survival is a history, so this is a very up to a point old, but still merited survival curves of the three groups. So the good, the bad, and the ugly. The good group is usually olfactory neuroblastoma and localized adenoid cystic carcinoma. The second group, the bad group, is the squamous cell carcinomas, adenocarcinomas high grade, especially the non-intestinal type, and then the ugly group is then the SNUC and the sinonasal melanoma. How do you manage sinonasal tumors? It's all multimodal therapy. Very rarely you can stay just on one single modality, such as a radiotherapy or surgery. And this is also the same story that is from the Ian Ginley collaborative study group, which is the only basic knowledge that we have how different tumors behave compared to the histology, or which are the negative impact prognostic factors, and this is the invasion of the bone and invasion of the dura, and of course the positive margins. If you leave the positive margins in a resection of the sinonasal cancer, as in any cancer, the prognosis is much worse than if you can achieve negative margins. So outcomes, the SNUC is one of the most intriguing sinonasal cancers in the later years, and it's amenable to much of the research because they have a very poor prognosis, but you can achieve a very good local control, and the patient die out of the distant metastasis because those tumors metastasis very early in the course of the disease, while a local regional control with a trimodality treatment, that is surgery, post or preoperative chemoradiotherapy, is and the local regional control can be achieved, which is very hard, as you can see on the right slide. In the previous years, it was thought that surgery has no role in treatment of the SNUC, but in the recent years, and what we have seen also from personal experience is that at one point you have to put the surgery into the treatment of the sinonasal cancer if you want to have local control and improve the quality of life of the patient. Adenocarcinoma is sinus adenocarcinoma is the cancer that it has most of the research because it's the most common one, especially here in the north region, especially in Italy, in Slovenia, because of and Austria as well, because of a lot of woodworkers, and as we know, wood dust is one of the cancerogens that, or is the main etiological factor for the intestinal type of the adenocarcinomas. Christos has put some work together on this in this paper where people are talking about endoscopic versus craniofacial or open-up approaches, and they compared different types of surgeries, and it has been shown that endoscopic approach, the same way as it has in inverted papilloma, it has some sort of advantage to the patient in regards to the quality of life, also in the management of the sinonasal cancer. So there's less complications, less hospital stay, and people are generally doing better if you can do an endoscopic resection, and this has been the question in the recent year. So the factors influencing the resection of the sinonasal cancer is their extension of the root, and we know that mainly we're talking about whether it goes to the brain, it goes to the orbit, or it goes intracranial in a middle cranial fossa. So management of the sinonasal cancer, you must decide at the beginning because of your previous experience and your knowledge from the work of the other researchers, is that whether you're going to do the resection or treatment with a curative intent, or you're going to do with resection with a palliative intent to improve the patient's life. So, can you cure those two patients? You can see that there's quite a similar CT MR scan on both sides with a massive intracranial invasion. You can say that maybe this, even in the orbital invasion, those two patients are basically, you could put the same. Well, one is SNUC and the other is dystocia neuroblastoma. So the histology here is going to give you the guidance, or is going to give you the decision-making process and the pivotal point, what they're going to do with those patients. So in the first patient, you're always balanced prolonging the life and remaining and the quality of the remainder of the life. So it's very easy to do a large resection with a instant and constant drop of the quality of life, or you can do in a little different way. So this was a 26-year-old male with which we performed a post chemoradiotherapy endoscopic resection with a good quality of life, and the patient lived for another year and a half and died of distant metastasis. So it was like we knew, and you can know that with this kind of extensive T4 or T10 cancer, if you want it, you cannot cure this patient, but you can prolong his life with extensive quality. Some tumors like this adenocarcinoma, it's very easy to manage endoscopically. We all know how you do that. So it's the basic centripetal resection of the tumor with its central debulking, and with disassembly of the tumor, as pointed out by Paolo Castelnuovo. So what you do is that you first debulk the tumor, then you do the resection, and you find the margins around the tumor, which is usually below, between the lamina papyracea and the periorbit. Then you follow your resection up to the skull base. You resect the base of the skull and the dura. You take the margins, and even in adenocarcinoma, it is prudent to resect the olfactory bulb, because it has been shown that there is an invasion through the olfactory phyla, and then after the resection you cover everything, or you do a duroplasty in a different ways. This was a case of the nasoseptal flap from the opposite side, which could be controversial, because there are some data, especially from the Varese group, where the adenocarcinoma in the woodworkers is a multicentric tumor. We haven't seen that, and more or less all those patients who are having a T3 carcinoma are also being treated post-op with the radiotherapy. So it is controversial. So this is again intestinal adenocarcinoma and post-op results. Esthesioneuroblastoma that was seen, debulking of the tumor, resection of the skull base, and resection of the intracranial part of the tumor, and ending up with the post-operative situation like this, and then post-op, as you can see, the result of the resection of the whole skull base. Squamous cell carcinoma with invasion intracranially and into the soft tissue. The problem when it comes to the invasion of the soft tissue, the resection of the endoscopic resection is limited, at least in our hands. We believe that in those cases, more or less an open approach is warranted, as it was performed here, a classical craniofacial resection with a reconstruction, then with a free flap and augmentation with a titanium mesh. So, with experience just in an endoscopic group, it's a very diverse group that we have seen from SNAC to adenocystic carcinoma to the malignant schwannoma, but most patients are adenocarcinomas. What we have seen that yes, adenocarcinomas are having the best prognosis. We also had a good results with sinonasal melanomas and very poor results with, let's say, malignant schwannomas and the SNAC. So this is what people say also put into the research what you can find in the papers. But it's a very small group, and every institution have their own little small group, and it's very hard to put anything, let's say, together that would be as a guidelines, except expert opinion. But what we have concluded from the recent research and from the experience and from the papers and the evidence that has come and is still coming is that endoscopic resection survival rates and local regional control rates are comparable to the historical survival rates with craniofacial resection. It's a diverse pathology because of the different histological types of tumors, and this basically is the pivotal point on your decision making, and you have to be proficient in what you're doing. So it's not just something that you just extend your surgery from the surgery of the nasal polyposis. It has to adhere to the oncological principles and management of other skull-based tumors. Thank you very much.
Thank you very much for your wonderful presentation. Are there any questions?
Very nice presentation, very good talk. Just a comment about the slide. I liked very much the big five and the unclear border between the squamous and the SNOOC. So I think that basing upon the literature data and upon my own experience, if it's a real SNOOC, it will be very, very radiochemosensitive locally. So this confirmed SNOOCs, they usually don't need, in my experience, following resection. The problem is to diagnose them correctly. So if they are squamous, they are much less radiosensitive, so you will end up with surgery. If they are real SNOOC, they will answer. So a critical point, I don't know if you agree, but a critical point and a message we should deliver that you need a very good, dedicated histopathologist when dealing with this tumor.
Yes.
Do you agree?
Yeah, absolutely. If I have second doubt, I demand from the pathology to do a revision in the other institution so that we have let's say consensus on what kind of tumor we're dealing with, because on SNUC in our institution we start with a chemoradiotherapy, and then we go for the surgery if there's a remnant, or we just go for if there's no remnant. Usually those patients present with unfortunately with the distant metastasis, or I even have one patient that had metastasis in the lymph nodes. Again, it's a very unpredictable behavior, and therefore yes, I totally agree. And also we had quite a few. So the pathology of the sinonasal tumors, I didn't talk about that much, I just made a glance on it. It's very, very difficult. And even very experienced pathologists, often they cannot they cannot agree to disagree, or they don't agree on anything. So you send them to the 3 pathologists, and you're going to get three different opinions on what is going on. One, I remember, it started with neuroendocrine carcinoma, then it was something like a mucoepidermoid carcinoma, and the third, at the end, when we take everything out, it was adenocarcinoma, poorly differentiated. So it was like, it's always a very spectral disease, if you want it, and it's very hard to make. What I would also urge, and I didn't stress, is that once you do a biopsy, take a big chunk of the biopsy so that the pathologist can have some material to work with, because they usually can tell more if they have a little bit more of the tissue, because they see a little bit different nests of cells and so on and so on. Not just a little bit biopsy with, I don't know, ear forceps. Okay, yeah. So it's always let's make their life easier, which makes our life easier.